can catch up afterwards. And of course, everything from today will be circulated round to everyone who's registered, so you'll have access to the recording and the resources from the slides. So I'm just going to kick us off this morning. My name is Jen. I'm one of the network delivery managers in the Child Health and Wellbeing Network team in the ICB. I'd just like to welcome you all to our Huddle on Neighbourhood MDTs for children and young people. I hope that's why you're all here. And we're just going to start off this morning with a little Mentimeter poll. We're going to do a few of these throughout the morning. So we're just going to have a little test and hope that it works. And you'll probably be familiar with these from previous sessions that you've attended elsewhere. What Carol has cleverly done, if it works, because we all know what Teams is like, is to integrate it within the Teams app itself. So if you can see there on the screen, there's what looks like a little, oh, it's gone again, what looks like a little phone screen, and you can actually type your response directly into that box on the screen when it reappears. There we go. So what we just wanted to get a sense of to start with was to understand a little bit about what you envisage a community of practice to look like for Neighbourhood MDTs before you hear the content from today. So from your understanding of this area of work so far, what do you think should be included in a community of practice around this? So there's no right or wrong answers around this. It's just, who do you think would be useful to include in a community of practice focused on Neighbourhood MDTs? So you can type it directly into the boxes there on the right of the screen. You can type in up to 3, and then it will magically create a word cloud for us. I get very excited by this sort of thing when it actually works. That's great. Perfect. So we can get a sense there of the sort of roles that people think we should be including. Some of you will be in those roles and are here with us today. Some of them might be missing from this session and we'll need to do some follow-up work afterwards. But it's just a really good... Sorry to interrupt.
There's quite a lot of us who can't do it or see it.
Oh. I knew it was too good to be true. That's strange. I don't know why that is. I'm very sorry.
I will go and try and share the link in the chat function. So you should be able to then just click on it and input it that way.
Thanks, Carol. This is why we do the tests at the start, you see. We almost had it, didn't we? Maybe if people's teams are set up slightly differently because we've got it integrated. Oh, sorry, I can see the chat now. Everybody shouted at me saying it didn't work. I'm sorry about that. I think we've got some good responses there, though, to start us off with. So,
yeah, and I think the link seems to be working.
Some, but not for others, isn't it? It's a bit weird, that, isn't it? Yeah. Anyway.
Aren't these things always like that? That's brilliant. Fantastic. We're going to follow up and ask a very similar question at the end of the session, just based on what you hear through the content. So don't worry if you haven't had a chance to answer it just now. This is just largely a test of the system, which has been semi-successful. But at least we've got a good idea. Ooh, getting a bit of feedback there. Just make sure that everybody's on mute. That would be great. Fantastic. Right, we're going to move on. Thank you for your input there. That's really, really helpful. So I'm just going to give a little bit of an introduction to the Child Health and Wellbeing Network for those of you who aren't familiar with us, and just the context of where this work sits within the system in the North East and North Cumbria currently. These are just, you can read these at your leisure when you get the slides, but they're just some stats to show that the level of challenge that we have in the North East and North Cumbria with some of these key health inequalities, many of which are deprivation based, and we all know that some of the challenges are quite substantial. So this is the context in which we're working, that this way of working is designed to hopefully address. Just in case you're not familiar with the geography, with the North East and North Cumbria, so all the way from the tip of Northumberland there down to Teesside, tip of North Yorkshire, and over to the west coast of Cumbria. And the way that we work within the network is very much collaborative, cross-sector, working across the whole system. So anyone that has a hand in child health and wellbeing in whatever context, they're welcome to be part of the network. And we do work on a cross-regional and cross-sector basis. The populations, when we're talking about children and young people, up to the age of 17, it's about 20% of the population. If you up that to the age of 25, it goes up to about 30% of the population. So it's not an insignificant number of people we talk about when we're talking about children and young people. And obviously, we always say that they're 100% of our future as well. So they're worth investing in. So the Child Health and Wellbeing Network sits, as I said, within the ICB. We used to sit within NHS England until last year, until we moved into the local structure formally in the ICB. And we've always had this shared vision of believing that all children and young people should have that opportunity to reach their potential by us all working together as different organisations. And you can see there, that's what we call our priorities wheel. So these were the general priority areas that were determined back in 2018, 2019, when the network was first established, for the areas that we wanted to focus on. Given to us by those system engagement sessions that we ran at the time, with loads of professionals and lots of young people's input as well. So what we do generally is share good practice, as we're doing today, driving work forwards, trying to progress the challenges that we have, and just connect people together. So connecting experts and different professional groups together. So our Huddle programs like this today is very much part of what we do, along with delivery of a programme of work. Just briefly, you don't need to fully digest everything that's on here, but this is an overview of our team and the areas that we work on. This is me here. Inequalities and underserved communities is my main focus, but I have now picked up Neighbourhood Health and MDTs as a new area of work, and also comms and engagement, including our system engagement group, which some of you will be familiar with. And lovely Carol is supporting us today, is in the background doing the hard work. We have our own youth board who work alongside our strategic oversight group as a sort of shadow board arrangement, and they are facilitated by RISE North East. Currently, previously over the last couple of years, they worked on putting together a manifesto for how they want to work with the adults. And they've created that fantastic artwork that you can see there. And when you get this, I would encourage you to have a look at that YouTube link, which is a video of them explaining about the work that they've done. So if you're interested in that youth engagement element to our work, we would really appreciate you understanding that and sharing it and getting involved with our young people. And then finally, we always share this when we do our intros, because we think it's such a powerful quote. So as well as the work that we do in terms of delivering programmes, we also see our role very much as advocating for the voice of children and young people. And this quote from Sir Al Ainsley Green, who was the first Children's Commissioner for England, is a really powerful one. So it's just a reminder of why we're all here and trying to do right by our children and young people. So thank you very much for your attention. Now, I'm going to move on to Mike in a second. We're just going to run another of our Menti polls before I let Mike kick off the main session. So we're just going to do this to ask, once Carol gets this up and running, and maybe she'll put the link directly into the chat for you as well if you had trouble before, just what you're hoping to get out of today's huddle. So why are you here? What are you hoping to learn? What's your motivation for getting involved in this work? We'd just really like to understand a little bit about where you're coming from today, and hopefully that'll give us some pointers as to how the question and answer and discussion section will go later on, and we can tailor some of that support for you. Fantastic, can see some answers coming through there. Brilliant. Really helpful suggestions. Yeah, and we know that this is new to a lot of people, and we're all sort of finding our way together with this, which is quite nice. And hopefully learning from those that are already doing some of this sort of work as well, which is really valuable. Fantastic. I would also add, you're welcome to use the chat function throughout this morning's session. So as our presenters are talking over the next 45 minutes or so, you are welcome to pop comments and questions in the chat that we will pick up in the second half of the session. So do feel free to post your thoughts in the chat as we go, and we'll be able to pick them up later on.
Fantastic.
Fantastic. And I'm going to pass on to Mike now, our fantastic chair for the morning. Mike has been a long time collaborator of the network and was our original clinical lead. And we're very grateful to him for giving his time this morning, because he's a very busy man, but is really passionate about this work. So thank you, Mike, for taking us through this session this morning.
Thank you so much, Jen, for that kind introduction. And hopefully this is going to be a fantastic session. There's quite a number of people on, so we've got three brilliant speakers, but 2 presentations, and then after a short comfort break we will have time for questions, I hope. I will sort of invite people to pose their questions themselves if they wish to, but we'll try and make sure we capture some of the ones in the chat as well and make sure that they're fed in too. I'm sure there'll be lots of questions, and we'll try our best to sort of get a bit of a representation of things. So without much further ado, I need to introduce our speakers. So firstly, Mando. Mando Watson's a general paediatrician working in London, and has done an immense job of developing some of the thinking, putting it into practice, scaling up neighbourhood teams, which I think is one of the most challenging things, and has really taken the leadership role in that. And if anybody's not heard of it, the Connecting Care for Children, I'm sure Amanda's going to tell us a little bit about that, is really come from Mando and her team that she's assembled in London to do this, and it's now spreading around the country, and we'll hear a bit about this today. But Mando's also stepped into, well, what a very tricky time, into NHS England to become the children's lead for integration. And so I think it's brilliant that she's been given that support and a platform. Mando, I remember, came to talk to us, I think maybe the first or the second ever network meeting we had way back in 2019, I think, to really inspire us and some of her work that she was doing then. And I've been watching her work since, and to see it go up and go to scale is quite outstanding. And from my perspective, I'm just delighted to listen to her again, learn as much as we can as we in the Northeast think about how do we do this ourselves. So Mando, I'm hoping you're online and ready to go.
Hello, yes, I'm here. Can you hear me?
We can. Fantastic. Over to you.
Thank you for that lovely introduction. And I remember so well our trip to Newcastle, and very fondly. I'm a bit sad that Teams has meant that we don't do that anymore. And I was really struck then by the very strong ethos of integration, the culture that you already had of people coming together from all the different agencies, all the different elements that support child health. So I have no doubt that the Northeast is already doing brilliant things and will, go forward very swiftly and very well because you have those foundations. Now I'm going to try and rattle through quite a lot of information in a relatively short period of time. I'm going to aim to finish by 20 to 11, maybe shorten that if I can. And what I prefer to do is cover things quite briefly and maybe assume quite a lot of knowledge, but then please come back to me with questions at the end, interrupt me if necessary, or put stuff in the chat. I'm also going to try now to share my slides so that I can control, but I am on a new system. And I'm not sure if I'm going to be able to do it. Let's see.
And yes, we can see.
Is
your
that
screen.
sharing?
Well, we're seeing your team screen and not your slides quite yet, but.
So I'm looking at my slides. So if you're not, that's not great, is it? Let me go back.
So it looks like when you've shared your team screen rather than your slide screen. Does that make sense?
Yeah. Choose what you want to share. How about that? Let's see if that works. Are you seeing my slides?
We are seeing your slides now.
Hurrah, golly.
Hurrah.
Thank you. Right, let's go. That was an annoying waste of time. Right, so what I'm going to do is briefly cover sort of what's this all about, and think about the national picture, and the reason we have this national initiative now, the sort of impacts of the work that you very kindly, generously referenced, Mike, in your introduction, but actually all over the country, work of this kind that has had significant impact. So, and it's the impact that has driven that national commitment to make this happen. I'll try and give you some case studies. I have a lot. I won't do them all, but the slides that I prepared, I've shared with Jen, and if she may have already shared with them with you, if she hasn't, she will. So you've got a sort of few things there to dip into after the meeting, and then think about how we got started, what were the challenges we faced, and how we overcame them. So let's whiz through that. This is a picture of an outline of the national picture, and the government has been driving towards neighbourhood health for some time. It's been called different things over the years. The neighbourhood health label is this year's label. I hope it won't change because I think it's a good one. But we had in January the priorities set for the ICBs and for providers to move to a neighbourhood health model, and that was swiftly followed with some guidelines for adults and children. And then in February, the bottom box was the detailed guidance on neighbourhood MDTs for children and young people, and there's a link there for those of you who aren't familiar. And if you have seen the NHS, if you've read the NHS plan, 10-year plan, you will see neighbourhood health peppered throughout it. It's very, very strong on it. In that framework for children that I mentioned was published in February, this is what it looks like visually. I'm a visual person, so I find this the way I like to organise my thinking. For those of you who are visual, I hope it will help you too. So there are 5 components, these blue circles at the bottom, and it is saying that actually we need to be, well, at a population neighbourhood level, and that is really organised around the GP practice population, which has strengths and challenges. We need to be identifying the children who have need. We need to be using the multidisciplinary team in order to discuss those cases and identify what is the best way of drawing in resource to support them. We need to be very strongly engaging with the service users in order to, sorry, that's up here, in order to understand where they're coming from. And we need to use the opportunity of these MDT, these multidisciplinary team meetings, to share knowledge. And within that, there will also be an element of GP patient-facing care, so a clinic, some sort of consultation. And hopefully you will understand why we have all those elements as we go through it. But there is this will be driven by bringing hospital paediatric or specialist paediatric expertise in or out of the hospital much more closely to the GP practice. So you'll have at core a GP and a paediatrician, but also a mental health professional. And it was interesting seeing in your word cloud earlier how much mental health was in there. And I think that is such a priority for all of us. And what happens as you start to organize yourself in this way is that you start to actually make much better use of the other resources in the system. And we have extraordinary resources in these two sort of lateral boxes, and some of you will be familiar with and like the terms horizontal and vertical integration. For others it may not work, but I think it is recognizing that across the system we have important resources and we need to use them better. So and actually, just to, again, I think up front, to give you the shape of this, I think people often find it quite difficult to understand what are the different, this isn't showing very well. Let me go to full, that's better. So the bit I've just been talking about sits in this top box here. And I will go into a bit more detail. It is how the NHS can organise itself better to bring specialist expertise closer to primary care, closer to the users of the service. At the same time, we have extraordinary resources, really precious resources that are organised through what some people call family hubs. Not everybody has family hubs, but most people have children's centre or something similar that is generally organised primarily around local authority assets. And that is a very important team as well, multi-professional, multidisciplinary team. And actually there will be individual professionals who will be the glue between these. These are connected. They don't have to be one team. There is a team here that's based around health, but broadens out to the social determinants of health. There is a team here that is based around social resources, but can draw in as needed health resources. And actually locally, you may have some really brilliant examples of youth hubs or mental health supporting teams or other multi-professional neighbourhood-based teams. And those need to continue. It's not about removing those, it's about connecting those. So I hope that helps with some of the thinking. And these things are now all over the country. And we have this map of places that we know are doing this type of work already. If you know of a dot that's not on that map that should be, please let us know. And on the left, you'll see a number of references that have demonstrated, as I said earlier, that this work actually has had an impact. And that is why NHS England, the Department of Health, the 10-year plan, the spending review of the Treasury have all now started to back this way of working. So here are some of the impacts. I'm going to start with patients because that's what our service users, that's what really matters. And there has been overwhelming positive impact on patients and families and service users. So I like the one at the bottom best, because actually this is about, if we all reorganise ourselves, but our service users don't feel any differently about the system, they'll carry on using the system the way they've been using it. But what we're hearing from them is that as a result of seeing a paediatrician with a GP in their GP practice, they see the two working shoulder to shoulder, they feel differently about their general practice, and they feel much more confident about using their GP practice for child health problems. And actually, if we have a system by which our families know how to access healthcare through their GP, and they know their GP can draw in specialist resource, that's a very robust system. And it means that we get much less of that scattergun approach that we've been seeing with families going to see their GP and A&E and the walk-in centre and 111 and all for one simple problem. So, average of 3.7 contacts with healthcare professionals for a simple cold. We have to change that. So it's really important that the workforce also feels that this is the right thing for them. And actually, we found that we've taken a very strong learning ethos. It's not about pathways and pushing patients through a system much more efficiently. This is about everybody who manages and supports child health being part of a team that supports them, that they learn from each other. And we do all learn from each other in these models of care. We've been able to be much more proactive. So we've been able to actually say, who are the children in this population? What are their needs and how can we best meet them? And we've had some deaths from asthma locally. So we actually did a big piece around asthma. You guys are the sort of leaders on asthma in its multifaceted approach. But what we did was bring a much more educational approach into for asthma by doing an asthma-focused multidisciplinary team meeting and an asthma-focused clinic for one of our monthly interventions. And as a result, we found that we were able to improve everybody's confidence in managing asthma. And for the educationalists amongst you, I do know that confidence is not always a good thing to have, but definitely learning and improved knowledge and improved capability is a good thing. And this is a model of care that enables you to do that. The other thing that was really powerful and very important is the impact on access and equity. Now, you know the inverse care law, you know that almost universally, the people who live with the greatest deprivation are the least likely to access healthcare. There's very strong data on that. However, when you organise yourself in this way, where actually you're delivering much more through and with primary care, you end up reversing that inverse care law. So this is data from colleagues at the Evelina, in South London, who were able to demonstrate that if you are in the deprived quintile, you are more likely to access healthcare. We're disproportionately accessing healthcare in a very positive way if we're organised in this way. This is some data on how the system responds to a GP who has a concern and needs help. And in a conventional health system, what they have to do is write a referral letter to the hospital, who sometime later might see the, will see the patient. But actually, if you organise yourself differently, you have an opportunity to have a very different outcome. So in one of our GP hubs, so that would be a practice population of 30 to 50,000, and in this case, it's a group of 3 practices. It was 1 practice actually, it was 10,000 population. We prospectively monitored over 7 months what was happening, and the GPs actually chose to bypass the hub and refer to the hospital for 50 patients out of the 363, because they knew that this was going to need something that couldn't be offered in the GP practice. For the rest, they either booked into the once-a-month paediatric clinic that takes place in the GP practice, or they booked into the monthly multidisciplinary team discussion. And 313 children were managed through that. And of those, nothing more was needed for 259. 33 needed onward referral. Almost all of them didn't need onward referral to the paediatrician. They needed, it was deemed that actually what would be really beneficial for them would be to be supported by another professional, dietitian, school nurse. Some of them needed a specialist doctor. So, and 21 we didn't manage to follow through. This is the very much more formal data evaluation, which was published, this one in 2015. This was much more recently, but it's showing you that if you organise yourself in this way, you are knocking out 80% of outpatient, up to 80% of outpatient referrals to the hospital. So in that terms of hospital to community shift that the NHS plan is wanting, it's very powerful. We also had an impact on A&E attendances, on admissions. It is a much more efficient way of working. And there's more data on that if you want. Okay, I'd rather go into clinical cases because, and it's interesting that the sort of specialist team, I'm just looking at the chat and the specialist teams who want to be involved. I think you need to be thinking about whether as a specialist, you're better off supporting your general paediatrician who can have the relationship with the GP practice, or whether you actually have enough activity in one of these hubs to be able to actually do a once every 6 months or once every year clinic, or whether you might do a once every year MDT to discuss cases and get people to know who you are. There's different ways of doing it, and there is not one way to do it. There's no single way of doing it. Right, here are some cases. So if you think about a GP who has been looking after a baby with very dry skin and possibly eczema, there's a history of food allergy, and they want to know about breastfeeding. And through a bit of contact, some photos, get some advice, and you get this ability to see what emollients do. And you probably don't need to exclude anything from the diet. And actually, as things improve, that is the definitive answer. So you're allowing, you don't have to have a single answer. You don't have to wait 2 months till the follow-up appointment in order to give a bit more feedback. You can do it in that much more dynamic way. Here's a 3-year-old with abnormal movements. Is it epilepsy? What should we do? Says the GP. And instead of, again, waiting 2 months to be seen, only to find that the movements have gone away, actually what you have is a bit of an exchange around getting the parents to video it, make sure the blood pressure's all right. Actually, there was this very sort of illustrative case where, in this case, things got worse and the mother ended up having to come to A&E with the child. The child was given started on anti-epileptic drugs after the diagnosis was felt to be epilepsy. But because there'd been this connection with the GP, the paediatrician looking after this child in the hospital knew that the mother had mental health problems and actually was in temporary accommodation, bed and breakfast accommodation. So rather than dump a whole lot of responsibility and information directly on this mother in the hospital, what the paediatrician did was give the mother some support and information, but also let the GP know. And so the GP was able to help this mother come to terms with this new diagnosis and support her daughter safely while knowing she was getting the support she needed. You will be familiar with cases like this. A 5-year-old who comes to A&E. A&E has a way of responding which is all about preventing serious and urgent problems. This was a slightly severe and odd headache in a 5-year-old, so they organised an MRI and onward outpatient appointments. But because this child was in a hub practice, so there was a good relationship between the paediatrician and the GP. Actually, the GP phoned and said, I've just seen this child who came to A&E a few days ago. Child's fine. I don't think they need this onward referral. I don't think they need the MRI. And actually, it was really nice to see how that could be de-escalated through that relationship. Oh, I'm going to skip that one because it's going to take too long. But those of you who are hospital-based will see another sort of unnecessary set of hospital activity that could have been avoided. I think it's really important to think about the mental health element. So here's a mother who is seeking, so who's come to the GP and says, my child needs to see a psychiatrist. In the course of the consultation, the GP listed the fact that the child had witnessed the death of her grandmother. They were in the car together when it happened. But the mother said, no, the child was like this before the event. It's nothing to do with this awful insult, emotional insult. And actually the GP spent a long time and really felt that this was not didn't need psychiatric referral, but brought the case for discussion to the lunchtime meeting. And there was quite a lot of input from other professionals. The school nurse felt that she could find out a bit more from the school. The mental health practitioner was able to give some information about a really nice service that was available locally for bereavement support that could be a good fit for this child. And actually the school nurse spoke to the parents, spoke to the staff at the school, and actually the staff at the school were saying, this is a shy child, but the child is participating fully. There's nothing outside the ordinary. And all of that feedback enabled this child to be supported and the mother to feel confident that the support she was getting was right, a little bit of bereavement support, a little bit of reassurance, and no need for referral. And this is how we're using the wider team. Here's an 8-year-old boy, well, it's similar, that's too similar to that. I'm going to go on to this one. This is a mother whose GP was worried. This was, she had 5-week twins. She was in poor housing. She didn't think this mother was coping, and actually invited a perinatal mental health professional and midwife to join the multidisciplinary team meeting. And it is worth saying that these multidisciplinary team meetings are not 1-hour discharge planning multidisciplinary team meetings. These are quick fire, 5-10 minutes per case. But you might just come in for one case if there is a case that's relevant to you and not stay for the whole thing. And actually a whole lot of information emerged as a result of that conversation. The child had been had a child in need plan and had been stepped up to a child protection plan, and the GP and many other people weren't aware. Mental health had discharged the mother, so actually she wasn't getting any support, and the social prescriber was able to step in and take over. Things weren't going well for housing, and the health visitor offered to step in, go and do a visit and get some more data. And actually nobody had thought about the other 3 children. But what I love most is this quote from the GP. I learned so much from my MDT colleagues, even if they're not directly involved in the case. So you get a lot of hidden benefits from managing the one case. How am I doing for time? I've run out of time, so I'm actually going to skip 2. I'm sorry, Mike, for overrunning.
We've got enough time for another 5 minutes, Mando, because we've got a generous amount of question time. So please, feel free to use another 5 minutes if that's okay. Okay,
I'll do that then. We started by actually doing a little bit of this on a very small scale and then designing something that was commissionable. And when we involve families in that design, they built themselves into the model. I think that is really important, not to just consult with and involve families once in your design, but to do it iteratively. We started off just having the core professionals in the room, and it didn't take long for a whole lot of other professionals to want to be there. And that's really important, is don't pay people to come. Design it in such a way that they want to be there because it's a good use of their time. It is really hard to involve patients and the public. We found that if you recruit young people, they grow up and go to university and, you know, they disengage, and parents of young children are super stretched, but do persevere and use all the different types of engagement that are already going on. It sounds like you're well on the, ahead of the curve on that one. When you are drawing those different professionals together, you do find the doctors dominate the conversation. You need to chair it in such a way that you encourage the other voices. We found as we started to spread from 1 or 2 sites to several, that each hub had its own flavour, some strengths and weaknesses. And what you want to try and do is get maybe the chairs of the MDTs to visit each other's, so that you can share the best practice across your network. We found it was really, really important not to impose. If you We started this a long time ago, and it was in the days of commissioning, and the commissioners would go to practices that were high referrers and say, you need one of these. It was the worst way of addressing it. Immediately the barriers went up. It's much better to say to a GP host practice, what do you want for your children's health? What will help you? How can we support you? And that really works. Inevitably, as you start to integrate, you get blurring of the boundaries, clinical governance, information governance. So you do need to take a bit of care with that. And for example, for information sharing, we're very clear. In fact, for both clinical governance, we just have a clear MOU. If the paediatrician has seen the case, they take accountability, they're accountable for that care. If they haven't seen the case, or if whichever professional just give advice, there's a person seeking advice who is accountable for the care. In terms of information governance, if you ever ask the family permission to share information, you said, I'm about to go into next week, I'm going to be meeting a load of professionals and asking for their help. Can I tell them about your child? Then you can share information with the name of the child. If they haven't given that permission, you can still ask for help, but you just do it anonymously. And we do have this problem of, I mean, that is a similar point to the one I made earlier. We do have this problem of perverse incentives with the hospital, and that needs to be overcome. And we're trying to do that nationally, but locally you might set up local tariff arrangements to help overcome that. And we have found that it is really a balance between top down and bottom up. Please do both, and your lovely network is such a great way of encouraging that sort of balanced approach. We have a number of resources that can help, and I've just put those in there, but worth flagging for those of you who are already doing this type of work, do join the national network, and I can happily share details if you'd like to do that. That's me done, I think. So I'm going to stop sharing and see. I haven't been able to look at the questions in the chat, so you'll have to guide me as to what needs clarifying or further detail.
No problems at all. And if it's okay for you to hang around for some questions, we'd be most grateful. What we might do is just go straight on to Helen and Annalise, and then we'll stretch legs for a few minutes and get straight into some questions. I think that was brilliant. It gave us a good overview, and also some of thinking about those challenges, particularly the end bit. I think was crucial to hear that about some of the challenges, but also the ways that one might think about things. I've written a couple of things down myself. I'm very interested in that blurring of boundaries and tightly bound teams and how you reform teams and the theory about going about that you put into practice. So we're now going to see an example and hear an example. I'm going to invite Helen and Annalise to speak, if that's okay. So Helen's done many things, I think, and is now head of commissioning for children, young people and communities, and working across the region, but I think based in the north, and has really grabbed an opportunity when we saw this coming. And I've been trying to think about getting a neighbourhood MDT going for 5 years, and I've failed until an opportunity came last year, and somebody introduced somebody, and all of a sudden Helen grabbed the gauntlet, and I'm so pleased that she did. And Annalise, I've known for a long time as a community paediatrician, and works in Northumberland, and they have been busy. So we're going to hear their early steps, which might be informative to us all as to how do you step into this direction. Helen, Annalise, over to you.
Brilliant. Thank you, Mike. That was a really lovely introduction. So I'm Helen Boyer. I'm Head of Commissioning for Children, Young People and Communities in Northumberland and North Tyneside. And I'm going to kind of introduce this presentation, talk through the first couple of slides, which give a bit of context to where we are. And then I'm going to hand over to Dr. Anna Buckland, who's going to talk more about the operational side of things and how we've got things moving. Next slide, please. So a lot of this has kind of already been covered, really, but I guess it's our commissioning vision. So, like everybody in this room, I think, we are keen to look at how we continue to improve our services and improve outcomes for families and young people. But that's against the backdrop where we have increasing challenges around capacity, referral numbers increasing, waiting times increasing, you know, and the system is really at breaking point in lots of different ways. So obviously we've worked before quite well, as Mando said, around collaboratively working and looking at some of our pathways to develop those and work more as a system together to try and address these issues. And this was a really perfect opportunity to look at that again. I think the key to this was that we already had, and Mando again touched on this, really, really well-established relationships across the system. We'd worked really well on some previous projects around children's mental health, graduate response pathways, and some mental health transformation work, etc., where we have pulled people across the system to work together. So those relationships were already there and conversations had already started. Next slide, please. So the timing, as Mike said, was everything. We'd already started to have those early conversations. We were really aware of the Connecting Care for Children model and the fabulous outcomes that we'd seen coming from that. And we started to talk about that as a system and how we could maybe do something similar ourselves in Northumberland. At the same time, there was an opportunity with the Children's Network that came along where there was a small pot of funding that we could utilise to help to galvanise the conversations and to move things at speed. So we got together as a system and talked about how we could do that, pulled together a proposal in record break time to look at how we could start that pilot in April 2025 with a pot of funding for £80,000 to help us to kind of act on that quickly. So that money is to kind of pay for clinical time, admin time, looking at how we can develop the processes, the data recording, the evaluation, etc., so we can move things forward. The idea, obviously, over time is that this becomes a self-sustaining model. It's not really about the money moving forward. It's more around a different way of working and efficiencies that can be made in the system to have a more seamless pathway. But obviously, to begin with, this injection of funding has been really, really great in helping us to kind of make things move at a much faster pace. The idea longer term will reevaluate the model, and we'll look to share the findings across the system and across the ICB to hopefully support other areas to do something similar. Next slide, please. So what have our enablers been to date? Again, I mentioned, I don't think I can emphasise enough the strong partnerships and collaborations that are in place. It's all about that. I think, you know, this whole pilot will work or won't work on the basis of the relationships that we have as providers and as individuals, and a shared vision. So, you know, talk about a commissioning vision, you know, but actually this is a shared vision across the system. And a real desire to do things differently and to improve our outcomes. Governance structure has been really important. So from an early stage, we set up an operational working group, as well as an assurance and oversight group. And we started these from the first month, even when there wasn't that much to talk about, but just to get everybody in the room to start to think about what we needed to do to move things forward and progress. Obviously, I mentioned the funding. That was a really integral part of this. But I think also it's around the willingness of people to support this. So I'm not just talking about those immediately involved in the pilot, but actually the wider context. So, you know, people like our data analysts and people who have given up time to come along and talk to us about how they can support the pilot and what they can do to do that. And at a time when capacity is really difficult and everyone's time is stretched, it's been really crucial that people have been really happy to become involved and to help to move this pilot forward. Again, like I say, later down the line, we're really hoping to be able to demonstrate impact and show the outcomes. And I mean, some of the fantastic outcomes that Mando showed around the Connecting Care for Children pilot, you know, we're hoping that we can do something really similar here up in Northumberland. And I'm going to hand over to Anna now, who's going to tell you a bit more about actually where we are with the actual pilot itself.
Hi, thanks for that, Helen. So I'm Anna Buckland. I'm a community paediatrician up in Northumberland, mainly based in Blythe, but kind of work across the patch. So as Helen has said, we had the funded pilot to get us going, and you may have got the impression from Helen that we started slightly backwards on this. So we got the money in place and then we're kind of learning as we go in terms of how we move this forward, but we've worked really collaboratively to try and get things off the ground and starting quickly. So initially we identified 2 areas to start with, which were Blyth and Ashington, and that was mainly because, if you know Northumberland, it's quite a spread out population, but the highest areas of population are in the central and south, which are Blyth and Ashington, and that's also where we see higher levels of deprivation and health inequalities. So they seemed the kind of ideal sites really to launch these. We do have a plan to kind of follow the model and to progress, but we thought it easiest initially to start with a MDT meeting with professionals via Teams, just so we could get everybody around the table that we wanted, and sort of work out from there how we move things forward. So we identified our core members, as Helen said, from that really good engagement early on, and I was very lucky that within Blyth we could get one placed up in June. So we had our initial MDT in June, which was really well attended by professionals, and I understand there's one later this month for Wansbeck, which is the Ashington patch as well. And I'll talk a little bit about our Blyth MDT as we move along. So in terms of what we needed to consider, we did quite a lot of this at that initial MDT with all the professionals around, just to make sure that we got things right. So we had a discussion about who the core team would be for that MDT, but also who we maybe would like to be as part of that wider MDT. As Mando said on her earlier slides, there's lots of professionals that can influence the care of a child and a young person. It's when is the right time to bring them in. And that's still an evolving discussion. And we didn't have school present at the time of the initial MDT, but a lot of the discussions that we had were, would that be useful to have somebody present from education? So that's something that we may consider moving forward. The next thing we need to think about is actually which children do we bring? So we had 2 within Blyth, there's 2 main PCNs, so there was 2 GPs attending, and they, because of the kind of time limit that I gave them, they went to their colleagues and said, who would you like to bring? And actually it was a really good range of children and young people of different concerns. So I think we discussed probably 10 children and young people together, ranging from preschoolers with speech delay to persistent respiratory symptoms to dizziness in young adolescents. So it was quite a mix of skills. And something that I think will evolve in time is whether it'd be useful to theme the MDTs, because of kind of to utilise the time and skills of the professionals there. But I think that'll take a little while till we know if that's the right approach to take. In terms of the more kind of organisational side, it was around information sharing, what consent we need beforehand to share details in terms of levels of parental young people's consent, and how comfortable the professionals were with the level of consent that we were kind of achieving. We plan to share information kind of a week in advance so that all professionals can review their notes if we've got consent, so that we come informed and knowing what we can offer to the MDT. The next big thing is about capturing the data and how we feed that back, and that's something that we're still kind of working towards, and kind of we'll move to that on the next slide if that's okay. So in terms of the main challenges that we're facing at the moment, so as I've said, we've only had that one MDT, and then later this month we're having another one in Blyth and one in Ashington as well. And the main discussion point has been around information sharing and what we as professionals can share when we come from different organisations. And I'm very keen that that's not a barrier to being able to support the GPs in facilitating the care for these children and young people. So it's important that we get that right. At the moment, we're just saying that GPs will bring the children and young people into the MDT, but the hope is over time that any member of that MDT can volunteer a patient to bring to discuss. So it might be from the Children's Hub, it might be from paediatrics, it might be from SIPs. So it's making sure that we get that right. As I said before, we're very keen that we make sure we value
the time of the professionals around the table for those discussions, and also make sure that the patients get the value out of those discussions. From sort of initial feedback from the first MDT was that everybody found it really valuable just for that wider learning as professionals, even if the cases we weren't discussing weren't necessarily relevant to their normal field of work. Everybody was really enthusiastic, thought there was lots of lovely shared learning. So I think that's probably the way to try and encourage things moving forward in terms of education for the professional team, rather than is it kind of what's the benefit of time. It's more around the educational side of that. And that goes into how we coordinate the time and the resources. Certainly from the cases we discussed, none of the 10 children then led to onward referrals into paediatrics. Some had previously been known to paediatrics, and it was about next steps. A lot of it was around sharing resources, so sharing and how we do that in a coordinated way to make sure that they reach the right people. Most importantly, probably, is how we capture the data and show the impact that this is having. And it's not only upon the impact in health, but it's the impact on education and the families and young people. So we want that engagement from the families and young people that have attended and getting some feedback from them, but also how we evidence sort of impact on school attendance, impact on other things that sort of outline quality of life and improvement. One of the things that we did look at was frequent A&E attenders, and that might be something that we kind of is an easy metric to monitor moving forward. Next slide, please. I think I've probably covered the next slide with my challenges and what we need to consider. But next steps is very much how we move this forward, the learning as we go, making sure we're flexible and adapt and learn from each MDT. Then there is the aim to kind of extend this to a face-to-face joint clinic between the paediatrician and the GP, but that won't be till later this year, and also a training offer once we establish kind of the themes and needs of the professionals attending these. I think that's probably everything that I needed to cover. I don't know, Helen, is there anything that I've missed that you feel is important, or Johnny, because I know you're involved in this as well?
No, I think that was excellent, Anna, not from me.
Oh, yeah, fantastic. Johnny, yeah, please do.
No, just to say, I mean, it's a really good overview, both of you, Helen and Anna. And I think, so I'm hopefully going to be able to start the Ashington MDT very soon, and we've had some positive conversations with one of the PCNs down in North Tyneside as well, so hopefully we'll get that something sorted out reasonably soon as well. I think it is that strength of relationships already, and that with all the different professionals, which has really enabled this to sort of move ahead at speed. And I'm quite keen that we don't, we're not too restrictive in terms of which patients we discuss to begin with, to let people see the value of it, and they can bring cases and children and families that they want to discuss. We've also got involvement of the Family Hub as well as private mental health workers and Northumberland CAMS, which is called SIPs here. We're representatives for those. One of the challenges I've had from some of the GPs is that there's quite a lot of other meetings that go on now around children where there are concerns, and how where this sits in relation to potential safeguarding discussions, and also that there are often team around the child meetings going on where there's lots of other professionals who go to those discussions as well. And so it's just making sure that we're clear about the purpose of this meeting when there's lots of other conversations ongoing and people are busy. But no, I think we've had a really positive response here. Well,
fantastic. Thank you, Johnny, for adding into thank you hugely for Anna, Helen and Mando. What I suggest is we're actually caught up on time just about. We will have therefore a 5-minute stretch legs, refresh yourself, grab a coffee, grab a glass of water, whatever you want to do. Whilst that 5 minutes occurs, I suspect Amelia, Jen and Carol are going to be busy looking at the chat and thinking about any questions there. But we will also open up to people to put hands up. But what I will start is with a couple of questions from the chat. And then we'll invite 1 or 2 hands as well. So see you in, what time is it now? 1 minute, 6 minutes past, yeah. See you in 5 minutes.
I've got a feeling that we may have lost Mike off the call. I can't see him on the list. Now, whether he's had a connectivity problem or not, I don't know. He did the other day when we were speaking to him, actually, so hopefully he'll be able to rejoin shortly. Mike will be facilitating the question and answer session for us. However, I do think that there's probably some questions in the chat that Mando could probably give some immediate responses to. I know you already have been responding in the chat, Mando. Thank you. And Helen as well, possibly you can pick up on this question around the funding for the pilot, which I know you mentioned in your presentation anyway, but just to clarify for people what that funding is paid for. And obviously you talked about that sustainability of the work and it becoming part of business as usual, and just how you sort of envisage that happening, because I think that's where people are coming a bit unstuck, is how this work is funded. Mando as well, I know you had some insights on that.
Want me to come in with a bit of, is that mic come back? No.
Sorry.
Okay.
Can you hear me again?
Oh, hi, Mike. Yeah.
Just crashed again. I don't know what's going on. I do apologise. I've lost 5 minutes there and trying to get, and I've been dialing into 2 different computers in a mobile, but it's finally come back.
It's fine. Don't worry.
Have you been using some questions or?
Well, we were just starting to talk about this issue that had come up in the chat around the funding for the Northumberland pilot. Fantastic. And then how we have it as business as usual when there is no currently identified funding. And I know somebody had also asked around the possibility of there being central funding allocated to Neighbourhood Health once the 10-year delivery plan for the 10-year plan comes out. So it was just to get Helen's and Mando's perspectives on the funding for this work in the first instance.
Fantastic. Should we start with Mando? Have you got any thoughts on, I know you've already put something in the chat, but have you got any comments, thoughts on the funding?
Well, don't shoot me, but I hate funding. I think everyone then starts chasing the money instead of the right thing to do. So actually, I think that's probably the first message. The second message is, I think you're not asking me I'm not giving you the answer to the question, but these are my thoughts. The second one is that it is really important to try not to fund people's time to deliver the service, because this has to be instead of what they're doing already, not as well as. But it is really helpful to spend the money on developing the infrastructure that will make it much easier. So, for example, spending some money on some resource that will encourage the culture change. So it might come into the multidisciplinary team meeting and work alongside the chair to help them to make the most of the MDT and draw out people's voices and use the time effectively. You might want to use some of the money to set up the digital systems behind the scenes that enable information to flow. I think that's a difficult one though, because you don't know how much local control do you have over that? I think those are tricky questions, and there is no doubt. So at a national level, there's no doubt that there will be resource in kind or money going into setting up systems that will encourage neighbourhood health. They will largely be around adult neighbourhood health, and I think we have to, in our local systems, work out how we can continue doing the good work for children, but be hand in glove with the adult work as well, so that there's the benefits of the system elements that are happening for adults are also realised for children. And frankly, I think in most places, the children's bit of neighbourhood health is advanced ahead of the adult bit. So if you can, ideally, you want to be getting your local systems to be guided by you as to what system changes are needed for both children and adults. There is spending review money for 3 years from 2026, but please don't wait for that. And we don't know, it may be very little. But the fact is that the Treasury has no money. So the fact that it's given anything to this is a really strong signal that they are supporting us and want this to happen. Those are my immediate responses to that question.
I've got some thoughts too, but can we go to Helen and then I'll add my tuppence thing.
Yeah, I think it's important to say to begin with that actually, as I mentioned, these conversations were already taking place before the funding was identified. So it was a kind of way of working that we were looking at already and that we would have been doing without the funding. It would have probably just taken longer to set up. The 80,000 has been used for resource, and it has been for individual resource. So we've used it for admin, as someone mentioned in the chat. I think that is an absolute crucial element to this. How does the information flow? How do we set the actions? How do we make sure everyone attends, etc.? So that coordination, I don't think, can be underestimated. And we have used some of the funding to pay for that admin support. The rest of the funding has been used for some people's time, and I agree with Mando moving forward. It shouldn't be about that. It's about a different way of working. But I think that initial injection has paid for some clinical time to actually look at how we can develop the model, come to events like this to talk about it, look at how we can put a bit of a blueprint together, how we can analyse and evaluate the work and share that. So a lot of that will be around how we can share the information out afterwards. I think there is an understanding absolutely within the pilot that this funding is for a year. It's not, it's not ongoing. So we absolutely need to think about how we build sustainability into that model. But I guess, again, it's more around a different way of working as opposed to doing something additional, as Mando says, to what people are already doing. So the hope is actually if we can identify the benefits of that and show the impact of working in that way, then actually people will want to work in that way moving forward, and the funding will not be really the key point. I have got a concern, and I'm not sure how we work this through yet. I think my biggest concern around moving forward with funding is the admin element of it, and how do we get that additional support and continue to fund that additional support. That's the one bit I haven't, we're still trying to work through that and how that will work moving forward.
Fantastic. I mean, my own feeling is on the funding side is that we're unlikely to see lots of money coming into this, but there may be small amounts, and it's how you use that is going to be crucial. I was also struck by Mando's slide, which I've been a sort of philosophically sort of a believer in for many years, is if it's the right thing to just start. And sometimes when you start things, if you start with enthusiasts, it can build momentum, but it also can die as well, and you can do a lot of good work, and if it's not supported. I think the wind's blowing firmly in this direction at the moment from the 10-year plan and from everything that's in there, that if you were a sort of betting person, this is the direction of travel. And therefore, if you do take that risk of saying, well, actually, we're going to reconfigure how we work, still see the same patients, but see them in a more efficient and effective way, that actually things are going to support you and flow in that direction. So I would think the MDT and people around, there's a real mixture of people on this webinar representing all sorts, and I think they will want to coalesce around this, because that will be the direction of travel of expectations. And if there's any funding out there to support things like admin, that might be it. I'm pretty sure it's not going to support expensive staff salaries. I don't think that's going to happen. I love it, but I just can't see it happening. And in some respects, maybe that shouldn't do, because the hope of this model and Mando's work has convinced us very clearly, and not only the Connecting Care for Children model, there's other models out there that are fairly similar, that actually is more efficient. It saves trips to the emergency department, it saves admissions to hospital, it picks things up earlier, early intervention, as we know it's all about. And that has a benefit to the health system now, but also hopefully for many years into the future as well. So I think it's the right thing. Two is if you can step into that direction and just get it going, I suspect now's the right time to do it, because I think then it will get supported and won't fall as soon as you come across the first big hurdles, is my guess. And in terms of doing that, you need an enthusiastic GP surrounded by a group of practices who are going to be supportive. You need an enthusiastic paediatrician to start. And then you hopefully find the people around you who are going to say, actually, we want to work with you. And I think that will be the key thing. I think there's an IT element, there's a consent element I want to explore, and there's also I want to pick up a question about the voluntary services as well in a moment. But that would be my thoughts on funding. We'll come back to Mando, and then I'll pick up another question if that's okay.
I just wanted to speak to the GPs in the room, and it's lovely that you've got GPs in the room, because that you are at the core of the NHS and you're at the core of this model for the same reason. And I think we often, I think GPs worry a lot. The ones who are enthusiasts get it, but the ones who are not enthusiasts do worry a lot about how they can allocate time to this and are used to being paid for time to be allocated. And I think what my ICB has done is to negotiate for an access tariff to be applied to cases that the GP is bringing for case discussion. And I think that has been helpful. I think it is a slippery slope as soon as you say, right, we're going to pay this person to come, but not that person. It sort of kills it. But I think you can find clever workarounds. The other way in which I've seen funding being steered towards the GP time is when we think about population health. Because actually the GP is the best person to say, right, who are the children in this footprint and what are their needs, that sort of population health, and are we, you know, it can be, you can think of it as an old-fashioned triage model, but I think it's much more than that if it's done well. It's about saying, this is a case that someone in the system is worried about. What is the right way of supporting this family? Do we bring them to the MDT? So that's a whole, and how do we organise the MDT so that it is meeting the needs of that child? So I think there is a bit of population health resource, health inequality resource that should be streamed in to help with funding, but actually to help drive that push towards inequality or better, more equity.
Yeah. Fantastic. We will pick up Sangeeta because I know Sangeeta is a GP and a GP lead as well. And your views on this would be really welcome, Sangeeta.
Thank you, Mike, and thank you, Mando. So absolutely agree. I did put a little comment in there about funding and about new resource. We all know that we are in a cash-strapped NHS. We hear that in the news every day, day in, day out. I think this is very much about redirection of resources, isn't it? A redesign of working. I think I'm long enough in the tooth to actually kind of remember a time when we had really good embedding of our health visitors in GP practices, where we actually had really close links with our community pediatricians, and where the system really worked because it was very much those interpersonal conversations. It was the knowledge about the family. It was actually the sharing, and there was trust between kind of colleagues rather than I'm not going to say a faceless name kind of, because we do know our colleagues in secondary care, but I think that certainly lent to much better care outcomes for our patients. And I think very much from this point of view, I hear what you say, Mando, from the point of view of the fact that, yes, it's about GPs wanting to work differently. And I think there is willingness, but at the moment, unfortunately, in GP land, I'm actually going to put it out there, and please, any other GPs on the call, do shout out that there is, I think, for a long time, there has been work that has been directed certainly kind of, into primary care, but there hasn't been a left shift of resource. But I think at this point in time, I think there are PCNs which have been formed, and there's the PCN Direct Enhanced Service. I think one way of, in terms of national policy, writing this in is to actually kind of write it into our PCN DESs, which then make it sustainable, because then it is something that actually can be driven. And I don't really know what kind of, what the thinking is on that at that level. I personally think that the greatest value is obviously with those practice links. But then again, I'm also kind of, a pragmatist and know that it is going to be impossible for you to do it across kind of, 30 practices in Gateshead and 28 or 33 in Newcastle. That's not going to be, to do it at that level would not really be kind of possible. So very much we're thinking obviously localities, neighborhoods, and I think PCNs, many kind of areas tend to kind of fall along the lines of PCN. So that would be kind of the way, because once again, I was thinking, we're all here because we're all committed, but what is the downfall of this model is the fact that we're all enthusiastic, but we need to kind of look outside our group. We are almost self-selected. There is not going to be that same level of enthusiasm, and the sustainability of this model cannot depend just on a few enthusiastic individuals. It has to depend on contractual obligations being kind of drawn up, which is why I'm looking to yourselves to kind of look to drive that national kind of write-in to make sure that this works this time round. Thanks.
Well, there's a challenge. I think we are at an early point. You know, the 10-year plan has just been published. Everyone's now talking about the how, but so how do we, because it's light on the how, deliberately, this is high-level plan. It's up to us to drive the how in some respects, and for us to feed Mando and the NHS England team while it still exists in that format. It will still exist, but it'll have a different label. But I'm sure Mando will still be doing her work as this transition period carries on. So how do we help them help us, as it were? And I think there are the discussions about contracts, I'm sure, are happening. I know they're happening, but actually what are the drivers? And there is going to be incentivization has to occur somehow, and we know that, but at the moment I haven't seen the detail of that, and I think it's probably early days, I suspect, for us to know that. But I think Mando's right in saying we shouldn't, not necessarily, if there are enthusiasts who have got, you know, a location, a clinic room that could be suitable, particularly with the family hubs. We're lucky in the northeast to still have a few family hubs that didn't, you know, were short starts that didn't die completely, and they're being resurrected, and so linking into them I think is really useful. And if we can start, and Anna and Johnny, and perhaps start, I want one in Newcastle and Gateshead, and I want one down in Teesside and Cumbria as well, and just start. And we need much more than one or two in each area. There's going to be a lot more need, but if we can start in small ways, we'll learn a lot and position ourselves to be able to carry on. And hopefully the pilot, we've got a bit of money. I'm hoping from Helen's work that we will learn a lot about the how bit ourselves, so that we can share that through the network. This is how we did it. These are your barriers. These are the advantages. These are the costings that are efficient and we can do better, but these are the costings we just can't get away from, such as potentially admin might be a real stumbling block if we can't address it. So I'm kind of hoping that we can get ahead of the curve, but I think Sangeeta, your challenge to the national team is absolutely right. It needs to be built in somehow as to usual work, doesn't it? Otherwise it won't work. So if that's okay, I'm going to move on to another question. I'm going to ask a bit about the voluntary third, but there's one little just comment I want to make first about training. I think is interesting. I've been having chats, because I have another hat for the Royal College of Paediatrics and Child Health, and we've been linking with the RCGP as well as two crucial colleagues and colleges, and we're hoping with the Royal College of Psychiatrists as well. There is going to be a training element for this, because this is a slightly new way of working. But the advice we're going to be giving there, and I'm sure Mando will probably say this better than I could do, it's stuff we're already doing, it's stuff we know about. It's just getting the right expertise together to share that knowledge and work closely together. But it might involve some training changes in how we support not only GP trainees, paediatric trainees, and then there's the wider staff who, you know, who will be working in these teams as well. So there may be training changes that will need to follow from this. And I don't think the Royal Colleges they're currently quite engaged with this, and probably won't be shy of stepping into that space and being quite supportive. So I'm hoping that, you know, it's slightly the cart before the horse, isn't it? We're getting things up before the training occurs, but as we say, it's not new work, it's stuff we're already doing, but possibly in the wrong places and very inefficiently. But we hope we can support the workforce of the future into feeling really confident and comfortable in doing this. So it won't just be the enthusiasts like Sangeeta and me and Johnny and Anna. It will become almost part of the way, well, this is how we do healthcare in the future. But unfortunately that process might take, you know, it's going to take 5 years probably, isn't it, to filter through, but that will be happening in parallel. So can I move on to the question? I don't know whether Ange Broadbridge is wanting to, if you're still online, Ange, do you want to pose your question about the voluntary sector? And I might give heads up to Toby, because I might bring you in to think about the answer to this. But Ange, do you want to say it, or do you want me to read it out? If you don't speak up, I'll read it out.
Thanks, Mike. I'm Ange
Oh, brilliant.
Broadbridge from Ways to Wellness. We've been working on a space, children and young people's pilot, working really closely with Dr. Anna Basu, a consultant neurologist at the RVI, supporting children and young people through a whole family approach with social prescribing. So I'm really interested in how we make sure that social prescribers are really well connected. And it was really nice to see Mando's example of that working in practice for patients, and also to think a bit more about how we make sure that VCSE and community is really well embedded in neighbourhood MDT practice too.
So I'm going to take that to Mando first, and then if open it up to any, I'll probably bring in Toby as well. It will circle a little bit back to money, I suspect, as well, because the voluntary sector, obviously, it's not just about shifting their work. There may be a shift in some of their work and the efficiencies there, but it also, there may be a cost element too that we've got to understand. But Mando, you've had some experience at bringing in the VCSE.
Yeah, I mean, I think what I've observed is that almost by definition, the voluntary sector is very local and very variable. And I think that systems have tried to create directories that can signpost to the right bit, and that has always failed. And where I've seen it work is in those neighbourhood MDT discussions where you have early help present, or you have a school nurse present, or a health visitor who says, do you know that at the bottom of that family street is a drop-in centre, is a youth club, is a something asset? And it's extraordinary how powerful that is, because A, there is quite in the room quite a lot of knowledge of the voluntary sector, and B, there is that the knowledge isn't just a directory, it is lived knowledge. It is, I had a family who went there and X happened and it was really effective. So I think that that really makes a difference. The other bit is where I've seen, if there is a good local, strong local asset, they get invited in to do a little 5-minute mini presentation at the beginning, which helps create those connections and that visibility. So it's I think that is a real strong call for us to strengthen that truly local way of working through these neighbourhood models.
Fantastic. So I think this is what I think is quite powerful. I think there's lots of power in clinicians and GPs and paediatricians working together and being close to the community nurses, the health visitors. I think there's lots of power in that. In a sense, that's already there, but sometimes not disconnected or not working together. So aligning people in the same direction is quite powerful. But where this sort of, I think it's like that duplicative, multiplicative effect, isn't it? Where it can really scale up is if we're linking in with other local, things, assets, if you want to call them that. So, Toby, you've got bags of experience to think about localities and local assets, and how can, the models of social prescribing that I know you've pioneered as well, how can they help and can they fit into this sort of thing?
Thank you, Mike. And yes, it's a sort of honour and privilege to speak on behalf of the voluntary sector here. So, and lovely to hear you and Ways to Wellness. There's a big shout out to you and to Anna Basu with the Space Project. So I think, Mando, I would agree that that famously we are very variable in quality and spread across the voluntary sector. It is very hyper-local, and one of the implications of being hyper-local is that there is variability. But I think there's an important sort of aspect of our work here, which is potentially needs highlighting. So yes, we are an asset. We can provide assets. We can be the centre down the end of the road that needs to be kind of locked into the asset mapping that an MDT will be doing. But also we have methodologies. And I speak sort of specifically about Northeast Wellbeing and the Zone West project. We like to think of ourselves as a way of working as well as being an asset. And the way of working that we have, and this is kind of echoed across the voluntary sector, is that we can absolutely be child focused, we can be developmentally focused, and we can be networked across a range of resources in a way which statutory services can't be or find it difficult to be. So we can have a foot. We have 3 feet. Just to imagine having a foot in 3 camps. So we're sort of got 3 feet. But we're sort of in education. We can be in the GP surgery, and we can be in the local authority with its social care. And from that perspective, we can make a kind of assessment and presentation of the more kind of holistic ways in which a child may be expressing their vulnerabilities across those different zones. So I think that I'd just like to say that the voluntary sector, by way of conclusion here, is as well as being an asset down the end of the road, it can provide methodologies, and I know that colleagues in the voluntary sector would probably echo me on this point.
Fantastic. We'll take a couple of comments, and then I'll invite perhaps anyone wants to pose a question themselves. Just put your hand up now. If not, I'll be coming to Jen and Co to see if they've found a good one that they want to raise. Mando.
Well, I'd love to ask you, Toby, and for a bit more of your thoughts on this. I have a very, very wonderful local organisation that when we were starting put itself forward to chair the MDT, and I was interested in the question in the chat earlier about who chairs the MDT, because I think it was really echoing what you were saying, Toby, which is that there is expertise in that organisation in bringing different parts of the system together to meet the needs of the child and family. Actually, what we found was that our MDT, that was trying to get through 10 cases in an hour, was quick fire, very medical, and didn't benefit from that. But as we said, every organisation is different, and there may be expertise that would lend itself to chairing a clinical MDT. But I wondered whether actually that sort of role was better suited to the family hub children's centre type bit of the neighbourhood health, and how much you are experiencing. Are you involved in taking that sort of chairing role in that bit of the system, and what are your reflections from that? I don't know if that question makes sense, but interested in your thoughts.
Well, thank you, Mando. Yes, so from speaking from my experience in North East Wellbeing, yes, we have a lot of firepower. There are 3 PhDs working on the team, and we're very experienced as a group of professionals. So yes, we are sort of comfortable and confident about sort of in Team Around the Child, which is a school-based way of bringing together different sort of professionals to reflect on the needs of the children. But is that sort of any so yes is the answer. That may be variable across the region, across the country, so I can't speak for other places. But maybe being a chair is a useful role. But just to so I think where we are strongest is in coordinating the face-to-face work with children and making sure that kind of ripples across different sectors and zones of influence. So typically a child will be expressing their vulnerability using the limited language that they have, language of dysfunction, across school, across GP surgeries, and also relating to their communities, so social care and housing. So there's a number of different difficulties there, but when the voluntary sector is particularly good, I think, in bringing together those kind of bits of the pie, if you like, and then sort of presenting the needs of the child in a circle, in the round, and then organizing assets in order to fill in the developmental gaps which have been sort of highlighted by this holistic assessment. So, so I'm not really 100% clear what the chair of an MDT looks like in this context, but I would say yes, of course, we have experience which is directly relevant here. But it's, I think, as well, or more importantly, it's about highlighting the needs in the round of the children as expressed across different sectors.
So I'm going to just take one last one, Ange, and then we're going to move on from voluntary sector. I want to pick up another question as well. So last comment from Ange, if that's okay.
I agree with all of that. I love that expression, firepower, Toby. I think that's absolutely what we have in shed loads in the VCSE. I think there's something to highlight there around the independent and non-statutory nature of VCSE roles, which mean that often families find it easier to accept support through an alternative route. So they may not say yes to early help, they may not say yes to statutory service support, but may say yes to an independent VCSE support, which can sometimes help to open the front door to those other things. So I think there's a real role for the VCSE there, sometimes in buffering families to be able to say yes to find those statutory offers more acceptable.
Really nice way of putting that. Thank you so much. I am going to pick up a question myself, actually, that I think it might be useful. Maybe bring in Helen on this, if that's okay, Helen. Nicola Childs has asked about, I don't know whether you want to, if you're still on and want to ask the question yourself, about looking at different models, and particularly you've highlighted the Families First models, and there may be other models out there. And if you're online and want to unmute and pose the question, if not, I can read it.
Yeah, I'm still here. I think I've
Nicola.
just been working through the Families First guidance that's come out. We've been cited on what our local authorities have submitted, but when you use the magical power of Copilot and run the Families First guidance and the neighbourhood teams through it, there's a lot of similarities. I mean, there's a lot of differences, but there are some overlaps, and I guess it's those strategic conversations with our partners in terms of where we can have a strategic framework, I think, rather than, but I just think there's significant overlap. So I just wondered if other commissioners on the call had those conversations or were looking in that direction as well.
So Helen, I imagine this is on your radar, thinking kind of what's the landscape, what are the different models out there? Have you come across this as you're starting to establish, or have you got thoughts on it?
Yeah, so I agree, Nicola. I think, the Family First work absolutely aligns with the work we're doing. We already have had those conversations with the local authority in the early stages. So we've got early help and the family hubs involved with the model from the start. And we are talking about how we can develop that. Like you say, it's early stages, and we need to look at kind of, I guess, how we can overlap those priorities and potentially, as you say, have some kind of strategic framework so it kind of joins together in an appropriate way. We don't duplicate or overlap or miss opportunities. But yeah, local authority are definitely sitting around our table and involved in the discussions as we move forward.
And can I just ask, sorry, have you been involved in Newcastle? You're Newcastle, aren't you, Helen? Have you been involved in their
Northumberland.
Sorry, have you been? I get mixed up once we're going north. Have you been involved in Northumberland's submission?
No.
Yeah, and I think that's a lot of them have gone up through our safeguarding teams, which is fair enough. But I think I think there's that conversation from an ICB perspective around that. But I'm going to take those conversations forward because I've got a sinking feeling we might have missed a little trick.
Well, those discussions are really happening at ICB level now, and the how. People are really wrestling with how, and I think it's up to us and all people here who have got a leadership role, those in leadership roles, please be starting to question, how do we do this? How do we do this? But because I think we do need to find those solutions ourselves. But I hope we'll get a little bit of help nationally as well, which we clearly have today, but also over the next year or two. I'm going to invite any last question. We've got time for one more question before I'll we'll move into a sort of closing period. If not, I will close myself. We'll take one last question from the chat, actually, Jen, or anybody. Have you spotted anything there that you wish to highlight?
I think it potentially relates to the discussion we just had around the involvement of the local authorities. It was Martin Gray, who I think may not be on the call anymore, but he was asking about how the MDT discussion sort of relates to any existing discussions that might already be taking place around children with complex needs in particular, so like children with disabilities teams, etc. So it's just to make sure that that is linked up, and the distinction between these different formats of discussion, which I think Mando alluded to in her slides, that there is a link between these different hubs and different meetings, but it's all wrapped up in that how, isn't it?
So that linkage is important, and Mandy, you might be able to help us with it, because some of us, so those children, for example, with quite complex or chronic health conditions that are well known to health, particularly maybe well known to hospital services, for example, how do the MDTs and neighbourhood teams, one, make sure they're not duplicating, but two, link into, say you've got a child with cerebral palsy or a child with kidney failure, kidney transplant or something, that those linkages occur. And I'm sure you've seen that in your hubs. How in practice does that work?
Yeah, so I'm just putting in the chat one of my case studies that I didn't present. I wish I had, but it's one of my favourite uses of the children's hubs is with a child who's beginning to get closer to transition to adults, and actually seeing that child with the GP together is incredibly powerful as a way of helping with that transition. A lot of these very complicated cases sort of bypass the GP until they're adults, and then suddenly the GP has to take over, and the GP doesn't really understand the case, and the child and often the parents don't know that the GP has not a clue, and actually you can start to help provide much more robust care, not just for the child, but actually for the parents. I was a witness to one of these where the GP at the end of it said, "Now I really understand your child and I will help, but I also know you're dealing with a lot and I'm your doctor too and I will look after you." Something that the paediatrician can't do, but the family doctor can. So palliative care, a child who is newly diagnosed with a palliative condition, this is where actually bringing the team together to really understand the clinical issues and draw in support for the family from the wide spectrum of resources that are out there that are often missed because the medical bit of the system and the rest of the system aren't connected up. So that's a quick answer to your question.
It's a beautifully illustration as well, and I think that's a really powerful way to pull this to a close. We're going to have a few minutes just reflecting and ending on a little bit. I think Amelia, you're with us, and thinking about what's the network's up to into the future. But if that's okay, I'll wrap up with a couple of thoughts. Really, I did say at the beginning I'm really interested in teams and how they work, and this is in a sense it's a reforming of a team. Some of us who are old enough will think, well, we sort of used to do this in the good old days, and it's reforming some of the strengths of what we used to do, but hopefully in an even better and more powerful way. So I think there's something about tightly bound teams which is dead important, aren't there? Your GPs working teams and our specialists working teams, and our health visitors working teams, our voluntary sector working teams, and of course they become strong because they can rely on each other. They have relationships. They have a shared sense of values and vision. They have a shared sense of working. And it can be quite threatening to think actually we want to work differently. And I think the natural incentive would be to sort of keep those teams bound. But I think there's something also healthy in that fuzzy boundaries, because, and I don't think we should be afraid of it as long as we're aware of it, that actually, I think Mando said, as the model develops, you start to find that boundaries become blurred a little bit. there can be something really healthy in that. There can be something particularly risky in it too. So you have to be aware of that. But I don't think we should be frightened of it. And the reason I say that is because of this meeting, but also the work that, you know, Helen and Anna's now doing and Johnny's doing, and the work that the network's done before, is that when you speak to people, not only children and young people, their families, but all the professionals, they're all saying the same thing. They all want the same thing, actually. We want to see children to grow, thrive, and become robust individuals who can have the chance of flourishing and reaching their potential. And I know it seems trite to say that, it's a reminder of our network aims and ambitions, but it's and it's simple to say it, but it's just true. It's just a truth that we just need to acknowledge. So if we can get over our own selves in a sense of thinking that it's only me. So for example, I'm talking to my paediatric colleagues, and I'm sure John is doing the same thing about this actually. If this model's going to be pushed and you know, pushed forwards as the way of the future, you know, our paediatricians, my pals here, are going to have to get out of our offices, and we're going to have to go and travel. But actually we'll be seeing the same kids, but we might be seeing them with people who actually can do more than we can do in hospital. And we might avoid needless investigations, needless tests, very expensive stays in hospital, and all sorts of things. So I call to the paediatricians, there's one or two of us here, we need to get out of our offices. I'm the worst at that, and I would love to do that in the last part of my career. I don't count myself as a generalist, but I still think I could just about cope. So I think it's important for us. I think it's important for our GPs to say, actually, yeah, we know GPs under so much pressure, but can we work differently to free things up? We've also heard there from Mando the power of the family doctor. It's still strong, despite the pressure that it's been under. And we hear that from our GPs up and down the region, but I also hear it nationally as well. There's a very strong will from the GPs to make these sort of things work, but we need to find the way. I think we've also talked about the voluntary sector. I think that is really important because I think they can work in a more light, agile way than sometimes we're able to work, and can work across different areas. We're very lucky to have social prescribing, Ways to Wellness, and North East Wellbeing, two important charities, if you like, voluntary sector organisations up in the North East, have done some amazing work, both within the hospital. The Space Project's been mentioned, and the Zone West project. The Space Project looking at really complex children who get stuck in hospital, and how do we reconnect them into their community, and that's showing traction and efficiencies and working. Toby's work linking schools and health together around a model for primary school kids who are often left out of things, and how do you use key workers to work across those boundaries and connect families who are going through difficulties and children who are going through difficulties back into their communities to help them thrive. So we've got some great models up here. I think it's up to us as a community how we start to use those and connect them into these emerging models. I'm starting to think that actually out of, Helen, I'm just thinking out of your work might not come just a blueprint, if you like, of this is the how, but everyone will say, well, you had £80,000. So I think part of it is also setting some principles, and there might be a set of principles that we can work with. And part of it might be that it's about respect amongst professionals. It's about putting children and families first. And it's about looking for those efficiencies and embedding children and giving them strength within their communities. So there's something about sets of principles that might come from this as well, which I think, because the models you get in Cumbria, Teesside, actually they might be slightly different, because the facilities, the professionals might work slightly different or have different expertise. So the models might not all look exactly the same. And I think that's acceptable and totally fine, as long as people are aware of it. And those are my last kind of thoughts on this. But I hope that's been helpful. Can I just say a huge thank you now to Helen and Anna. Thank you, Helen and Anna and Johnny, for grabbing the opportunity and moving at pace. I'm quite astounded at the pace you're going at, but I'm really pleased you are. But that because you're experienced group people who talk to each other, and I'm so pleased you're doing it, and I suspect in another year's time you'll be telling us all about it, and we might be producing some sort of blueprint to share. And we'll also make sure we let Mando know of the outcomes of that, so that she can be aware of it and say across the country, well, this is what the North East are doing, you know. So there's a challenge there for Helen at some point. Please do share back when that comes. So thank you for that, and above all, thank you, Fernando, for sparing your time yet again. And expertise for the north of England. We really appreciate it. We'll stay connected, and we'll see where this goes. And I hope we'll do you proud and do the children and young people of the North East proud as well. So thank you so much. And with that, I will close it and end to Amelia, who'll probably just spend a minute telling you what else is going on in the Child Health and Wellbeing Network in the North East and North Cumbria.
Thank you, Mike. I'm going to just pass to Jen before
Jen,
I
please.
close.
Yeah, sorry, no, I'm just going to steal Amelia's thunder for a couple of minutes, just to do a couple more little Menti polls. Now we've reached the end of the session. One of our actions to take forward from today is the development of a community of practice around this for the North East and North Cumbria region. It's in our CYP transformation deliverables for us to do, but I think coming off today, it shows how desperately people need that forum to come together. And I know there's some comments in the chat from commissioning colleagues as well who are really keen to have something developed. So we're just going to ask another question similar to what we did at the start. So it's asking who needs to be in our community of practice. Now you know how to use this. Carol will put the link in the chat for those of you that couldn't access the little widget. Who do we need to include when we're developing these meetings based on what you've heard today? If it's the same as it was at the start, that's fine, but just in case you've had any other thoughts on it, just so that we can make sure that we're making the best use of it. And obviously we can think about the format of it as well, and we'll be doing some outreach and engagement around that. So please do give us your thoughts based on what you've heard today so far. It's basically our entire network membership list, isn't it, Amelia? When you look at those roles, it's like everyone that's engaged with the network somehow. Yeah, fascinating. VCSE front and centre there in the middle.
Yeah, and also the voice of the child, the young person, their families is going to be really key in this, and how is that going to influence it?
Yeah, I would just say that Amelia is our network lead for CYP and Family Voice. So she is linked into that young advisor group that I referenced at the start, our COI group, Know Our Impact. So Amelia is your link for voice through the network if anyone wants to have a conversation about that. Thank you for that. And then just lastly, Mando is keen to understand any support that the national team could offer around this as it develops. So there's just one more question coming up if anyone's got any thoughts around support that people might find helpful. Obviously we have links into the NHSE regional team as well. So just a free text box, I think, for you to, yeah. Just any suggestions around help that you might find useful. Obviously, as I said at the start, we'll circulate all the resources that have been shared today so that you can look at them in your own time. But if anyone's got any particular queries they want following up, and we'll take anything from the chat that we might have missed as well. Yeah, I think those case studies are really helpful, aren't they, to illustrate how it works in reality. Really brings it to life.
And can I ask, actually, while you're doing it, if you get good cases that you are in your existing model, please send them to me because I'll use them. Thank you.
Brilliant, thank you. And I'm just going to give Amelia literally a minute now to to squeeze in just the little closing section, and just how you can contact the network and get in touch with us in other ways.
Yeah, thank you very much, Jen. So the information I'm going to share is just around our Healthier Together app and website. There's a big refresh a couple of months ago, so it's worth having a look and seeing how the website's changed. But again, there's still the families area and there's still the professionals area, and there's going to be work done on the young people section moving forward, which is quite exciting because our young people are going to be involved with that. And then there's the QR codes and information there that you can access and share with colleagues. And if you'd like to contact Laura for further information, please do. We've got our Huddle, our autumn Huddle programme, which is firming up. So in August, September, keep an eye on Child Health Tuesday, where all our information is shared. If you don't receive Child Health Tuesday, there's a link to join the network that will be shared in the chat, and it will also be shared in the result. Oh, there we go. Already popped up. We've got our Blue Sky account, which is growing weekly, so please do keep an eye on what's happening there, as well as our system engagement group. So if colleagues would like to join that, it meets about monthly, and we look at how to support the reach across the system. We've got a range of resources available, and then there is plenty of opportunities to get involved by looking at the table. In the email that you'll receive with a bit more information from this event, there is a short evaluation survey. So if anyone has got any topic ideas for future huddles, please do get in touch, and we'd love to share pieces of work. So please keep in touch with us, and also sign up to the Community of Practice, which Carol shared earlier. Thanks, everyone. Minute past. Enjoy your lunches. No, I'm back to Mike.
Yeah, cheerio, everyone. And like you say, stay in touch. It's your network, not ours. So yeah, do stay in touch. Help us drive it and help us make it as useful as possible. I hope you've enjoyed the session, and I hope we see you all again. Have a good rest of the day. Take care.